Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, IIT Roorkee, and I am doing a course on health, humanities and disability. And under the caption, today I am going to discuss biomedical discourse in health humanities. Let us know what is biomedical discourse. So biomedical discourse in health humanities examines how medical language and scientific framing shape our cultural understanding of the human body, illness and healthcare systems. It analyzes medical text, doctor patient communication, and public health messaging as cultural artifacts rather than absolute objective truths. Discourse arises in interactions among people and serve as a means for accomplishing social actions. Meanings develop through the pragmatic progression of events and help align participants with their perception of immediate situations and relevant context, whether they are fictional or non-fictional, that language brings to mind. Language is created, used, and interpreted by individuals during social participation. Even when people reflect on their own identities, commitments, and actions, they are still engaging in social discourse. Language users endowed with a specific neurophysiological abilities and shaped by their individual language experiences draw upon socially and culturally available linguistic resources during interactions. These resources have been shaped by historical patterns of social circulation. However, individuals still create meanings and consequences based on their perceptions of unique situations and behaviors of their participants within those situations. Site of communication and the personal meaning system of the receiving individuals developed through a lifetime of social embedded language use as applied to the communicative issue at hand. These interactions over meaning may occur within the material space, but they also may occur at a distance of time and space mediated through recorded language. We may use language both to cooperate in building a stone wall physically in front of us, as well as to establish principles of chemical bonding in scientific publications, which, however, are indexed and accountable to the material chemical interactions in specialized experimental probes and in everyday life. Now, what are the key intersections of biomedical discourse in health humanities? Language as power. So, health humanities analyze how clinical vocabulary can distance doctors from patient. It looks at how turning a person's lived suffering into a clinical case alters the dynamics of care. Illness narrative. This field contrasts the biomedical model, which views disease as mechanical breakdown, with patient centered stories. These narratives capture the psychological, spiritual, and social impact of being sick. Critique of medicalization. Scholars study how normal human experiences like aging, childbirth, and grief are systematically redefined as biomedical pathologies requiring pharmaceutical or surgical intervention. So, visual and material culture, it explores how medical technologies from 19th century anatomical drawing to modern MRI scans shape how society visualizes health, disease, and normality. Now, what are the major areas of academic studies if we talk of biomedical discourse? So, first is narrative medicine, training clinicians to listen to, absorb, and be moved by patient stories to improve diagnostic accuracy and empathy. Second is disability studies, challenging the strict biomedical view of disability as a deficit to be cured, promoting instead of social model of disability. History of medicine, tracking how biomedical definitions of diseases such as mental health condition have evolved alongside societal prejudices and political shift. Language as power is central theme in the health humanities, exposing how biomedical discourse acts as an instrument of control, authority, and exclusion rather than just a neutral tool for communication. How clinical language asserts power. So the clinical gaze, biomedical discourse shift the focus from a suffering person to a malfunctioning biological specimen. By translating a patient's story into cold anatomical terms, The institution strips the individual of their agency and transforms them into a passive case. Second is esoteric jargon. The specialized Greek and Latin derived vocabulary of modern medicine creates an intentional knowledge barrier. This linguistic barrier reinforces a strict hierarchy, positioning the clinician as the ultimate gatekeeper of truth and patient as an unknowledgeable subordinate. Third is passive voice and objectification. Medical charting heavily favors passing phrasing like the patient was non-compliant or the abdomen was palpated. This specific syntax removes human agency, distances the provider from the emotional reality of care, and subtly blames patients for treatment failure. Coming to the mechanisms of linguistic control, the first is epistemic injustice. As we have discussed before, this occurs when a patient's subjective testimony regarding their own bodies is dismissed or undervalued by healthcare providers because it lacks objective biomedical phrasing. It directly silences marginalized groups, chronic pain sufferers, and neurodivergent individuals. Coming to diagnostic labeling, to name a condition is to possess power over it. Biomedical discourse dictates what is considered a normal body or mind and what is classified as a pathology or disorder. These linguistic boundaries directly influence legal rights, insurance coverage, and social stigma. Third is the war metaphor. Biomedical discourse heavily relies on militaristic metaphors like fighting cancer, invading pathogen, magic bullets. While motivating for some, this linguistic framing presses patient into an aggressive, combative stance and implies personal failure or surrender if the body succumbs to disease. If we talk of subverting the power dynamic, the health humanities advocate for a linguistic shift to democratize care and dismantle these rigid power structure. This is accomplished through narrative medicine, encourages doctors to honor the patient's natural language, metaphors, and storytelling style rather than forcing them immediately into clinical templates. Second is identity first versus person first language shifts power back to individuals by letting them choose how they are linguistically represented. For example, a person living with diabetes versus a diabetic. Third is co-created medical records, experimental practices where patients view and actively contribute to their own electronic health notes, turning the medical record into a collaborative dialogue rather than a unilateral clinical judgment. Illness narrative versus biomedical discourse. In this, the tension between illness narratives and biomedical discourse represents the foundational debate within the health humanities. It highlights two fundamentally different ways of understanding, communicating, and treating human suffering. So, the core distinction between disease versus illness is needed to be understood. In his seminal text, The Illness Narrative, Harvard psychiatrist and anthropologist Arthur Kilman established a crucial vocabulary to separate clinical mechanics from human experience. So, the first is disease, biomedical discourse, the malfunction of biological processes or organ. It is highly quantifiable, technical, and objective. Providers use diagnostic checklist, lab values, and imaging to map a deviation from psychological norms. Illness narrative, the deeply subjective, lived experience of monitoring symptoms and navigating disrupted life. It captures how a health crisis alters a person's identity, relationship, emotional stability, and social standing. So, the key points of collision is the health humanities analyze how these two distinct frameworks collide in clinical settings. The first is the reductive versus the holistic lens. Biomedical discourse functions reductively, breaking a patient down into isolated parts like an elevated A1C level or a localized tumor. Conversely, an illness narrative functions holistically. It details what Arthur Kelman calls illness problems: losing a job, experiencing marital stress, or mourning a loss of physical independence due to a diagnosis. Coming to the case histories versus pathographies, the medical system documents a crisis through a case history using passive, detached vocabulary designed to strip away emotional noise. The health humanities counter this with pathographies, first person autobiographical accounts, or memoirs of sickness. These stories articulate the anxiety, grief, and confusion that are systematically erased from institutional medical chart. Reinstitution versus quest narrative. Sociologist Arthur Frank noted that biomedical discourse is obsessed with the reinstitution narrative. I was sick, I took a drug, I am cured. However, chronic or terminal conditions rarely follow this linear path. Patients often rely on quest narratives where the focus shifts from a biological cure to finding existential meaning, community, and personal transformation through their suffering. Bridging the gap, narrative medicine. To prevent biomedical discourse from entirely silencing the patient's voice, programs like the Columbia University Division of Narrative Medicine train health professionals to actively listen to illness stories. This interdisciplinary approach teaches clinicians to decode a patient's metaphors and emotions alongside their physical symptoms, transforming the clinical encounter from a unilateral interrogation into a collaborative healing dialogue. If we talk of critiquing medicalization, the critique of medicalization is one of the most vital intervention made by the health humanities. It exposes how everyday human experiences, variations, and social problems are systematically redefined as medical conditions requiring clinical supervision, diagnosis, and pharmaceutical or surgical treatment. When fused with a critique of biomedical discourse, scholars argue that medicine does not just treat illness, it actively invents them through a specialized, authoritative language that strips individuals of political and social agency. Coming to the common methodology, discourse analysis is studying clinical language to find hidden biases, racism, or sexism. Archival research uncovering how marginalized groups were treated in past medical institutions. Close reading analyzing medical textbook ads or policies as cultural text. So, impact on healthcare exposing implicit bias, and this talks about to help clinicians identify unconscious racism, sexism, or ableism in patient care. Improving health equity drives policy changes by proving that clinical outcomes depend heavily on social justice. Amplifying patient voices values the lived experiences of marginalized groups over rigid institutional data. The core critiques and theoretical framework biomedical discourses talks about the intellectual foundation of this critique relies on several key theorists who challenged the expanding jurisdiction of modern medicine. So, first is Michel Foucault, Biopolitics and the Clinical Gaze. Foucault argued that modern states use medicine as a form of social control, biopower, and the clinical gaze isolates the human body from its social context and turning it into a site of institutional observation, classification, and discipline. Second is Ivan Illich, Medical Nemesis. Illich introduced the concept of iatrogenesis, doctor-induced harm. He argued that industrialized medicine medicalizes life itself, destroying people's intrinsic capacity to cope with suffering, pain, and death on their own terms. Irvin Zola and Peter Conrad, Sociology of Medicalization. Conrad tracked how behaviors once judged as bad, sinful, and unusual, like alcoholism, hyperactivity, or homosexuality, were shifted into the medical realm and classified as sick. This shifted the remedy from punishment or social reform to chemical management. What are the key spheres of critique? The health humanities analyze how medicalization and biomedical discourse after societal structure across several distinct domains. So, the first is the expansion of pathology, turning normality into illness. Biomedical discourse steadily expands the boundaries of what is considered abnormal. Natural life transitions are reframed as biomedical deficits. Reproductive life, pregnancy, childbirth, and menopause are treated as high risk medical crises, requiring heavy technological intervention rather than natural physiological process. Aging and dying. The natural decline of the body is often treated as a disease to be aggressively combated intensive care unit rather than a spiritual or familial transition to be supported. Emotions. Normal human grief, sadness, or childhood energy are frequently pathologized as clinical depression or ADHD, shifting the solution to behavior compliance through prescription drug. Depoliticizing social suffering. By translating systematic structural failures into individual biological abnormalities, biomedical discourse act as a political shield. Example, reframing the profound anxiety, depression, or chronic physical pain of an impoverished worker living in a polluted neighborhood as a simple chemical imbalance in their brain. The consequences. This discourse implies that the solution in an individual prescription drug effectively obscuring and protecting the societal systems, poverty, racism, environmental neglect, causing the distress. If we talk of corporate driven disease mongering in contemporary healthcare, the critique extends to the pharmaceutical and medical device industries. Corporations actively employ biomedical discourse to market new conditions to the public to expand consumer bases. Conditions like low T, low testosterone, or female sexual dysfunction are heavily promoted through clinical sounding jargon, transforming normal human variants into lucrative corporate market. So, the visual culture in medical humanities examines how medical images from 19th century anatomical drawings to modern MRI scans are not just transparent windows into the body but powerful cultural artifact. Biomedical discourses relies heavily on visual technology to establish authority, define normalcy, and make the invisible visible. However, these images also carry hidden social biases, ethical dilemmas, and power dynamics. So, the power of the image that we need to understand what are the key conceptual areas. The first is the technological veil and detachment. Modern medical imaging, that is CT scan, fMRIs, ultrasounds, translate a patient's complex suffering body into a digital, brightly colored abstraction. And the critique is that this visual discourse creates a psychological distance between the clinician and the patient. The doctor often treats the image on the screen rather than the human being sitting in the room. And the impact it reinforces the biomedical idea that reality only exists in what machines can capture, rendering the patient's subjective, non visual symptoms like chronic fatigue or deep grief less valid. Coming to the constructing the normal and abnormal body. Throughout history, medical illustration has been used to establish cultural ideals of beauty, race, gender, and health. And the critique is that historical atlases and modern textbooks have historically used young, white, able bodied male figure as the universal standard for the human body. And the impact is that when deviation from this usual standard occur, biomedical discourse has frequently pathologized racial minorities, women, and disabled individuals, treating their bodies as inherently defective or exotic variants. The visual politics of the fetus. Obstetric ultrasound technology provides a stark example of how visual culture shift political and social power. And the critique is that by visually isolating a fetus from the pregnant person's body using high contrast imaging, the fetus is linguistically and visually framed as an independent patient or citizen. And the impact is that this visual separation has been deeply weaponized in in legislative, religious, and legal battles, sometimes reducing the pregnant individual to a passive individual container in public discourse. Neuroimaging and the visualizing of the self. The rise of fMRI scans has deeply altered how society views human nature, addiction, and mental illness. And the critique is lighting up specific quadrant of a digital brain creates the illusion of an objective biological truth. The impact is that this intense visualization often oversimplifies complex human behaviors, experiences, and social traumas into a simplistic narrative of faulty brain wiring, ignoring environmental factors like poverty or structural isolation. To counter the detached nature of biomedical imaging, the health humanities have championed graphic medicine, the use of comics, graphic novels, and hand-drawn illustration in medical education and patient care. By combining text with subjective hand-drawn images, graphic medicine allows patients and families to visually communicate the messy, distorted, and emotional realities of illness, such as the disorienting fog of chemotherapy or the internal chaos of panic attack that a standard medical scan can never capture. The clinical gaze. Well, a foundational concept coined by philosopher Michel Foucault, this framework explains how the medical establishment objectifies the human body. The clinical gaze describes how doctors look at patient through a strictly biomedical filter, separating the physical body from the patient personal identity. So, separating disease from the diseased, Foucault argued that modern medicine requires the clinician to mentally isolate the pathology from the person. To find the disease, the doctor subtracts the patient's individual personality, emotion, and culture, treating these subjective elements as noise or disruptions to an accurate diagnosis. The specialization of the body talks about biomedical discourse that it maps human suffering into a strict grid of anatomical coordinates. The clinical gaze reads a patient's body like a text, translating a complex human life into localized points such as an abnormal tissue structure, a specific metabolic biomarker, or a digital pixel on radiology scan. Objectification and power. When a patient enters a healthcare institution, their body becomes a site of medical observation and classification. The clinical gaze positions the doctor as the absolute objective investigator, while the patient becomes a passive object to be inspected. Coming to the health humanities critique, the health humanities dismantle this biomedical framework by highlighting the distinct harms of an unchecked clinical gaze. Epistemic justice. When clinicians rely solely on what the clinical gaze can see or measure, they actively dismiss symptoms that cannot be verified by biomedical technology, such as chronic pain or mental distress. Depersonalization, reducing a patient to an interesting pathology or a room number, the appendix in bed 4, strips away human dignity and erodes the therapeutic alliance. To counter this detachment, health humanities advocate for a gauge of witnessing. This approach trains healthcare providers to look at the patient phenomenologically, observing their physical body while actively listening to, validating, and recording their subjective life narrative as a vital component of clinical care. This is all for this lecture. In the next one, we will continue with biomedical discourse in health humanities, focusing on further important concept. In addition, we will also discuss other important discourses like attention disorder and contemporary development. Till then, thank you very much.